Prognosis, what happens, what is the progression? So again, remember, this is a progressive disease. So normally after starting, from the day it starts, so prognosis from the start to another 15 to 20 years. Another 15 to 20 years is when the disease progresses enough that it ends up, the patient ends up dying. Now, what are the most common causes? This is important from steps as well. What are the most common causes of death in Parkinson's patients? Two primary causes. Many times the patients have difficulty. Of course, there are going to be motor difficulties. We'll talk about that in a second. But as part of the motor difficulty, this happens in Huntington's as well. Swallowing becomes a problem, and so patient starts aspirating, and the pneumonia and infections become the causative reason. So one primary major reason of death in Parkinson's is the infections. Second major reason is the gait instability or postural instability, causing falls and then dying because of falling. So that is these are the more important. 15 to 20 years, the disease progresses enough that infections and falls become the prevalent factors that can cause death. Now, what are the clinical symptoms? The clinical symptoms of Parkinson's, what happens in Parkinson's is, number one, and I'll draw that here pathology, and I think from the pathology you can very easily infer that why this happens. But number one, there is rigidity. So rigidity means that the agonists and antagonists are all tense or have high tone at the same time. With the rigidity, of course, there is extra pressure on the joints. So there is joint pain as well. Joint pain is not a direct problem from the Parkinson's, but it is because of the extra tone in the muscles. The rigidity type is cogwheel, where the patient, if you ask him to flex or extend, the flexion would go like this. So this is the cogwheels, as if there is a cogwheel and every cog on the wheel causes a bump. The reason for this bump, if you have read the musculoskeletals physiology, the reason for this bump is the muscle spindles. So muscle spindle and the Golgi tendon apparatus, when there is extra tone on them and the patient is trying to force and flex, let's say, his arm, what would happen is that his extensor does not want to give way. Why does it not want to give way? That is what we'll see, that because of the problem with these basal ganglia, which cannot inhibit thalamus properly, thalamus would excite the upper motor neuron system or the motor neurons, which would then increase the tone. So now, because there is extra tone in extensors and flexors, when the patient is trying to move the extensor, for example, in this case, I'm trying to move my elbow, the triceps would have increased load. That load would keep increasing to a point where the triceps muscle spindle and tendon would give the stimuli to the brain that, hey, we have lots of tension, and the local reflexes would suppress the tone in the extensor, and there will be a slight jerk and slight movement, and then the tone would come back. So that is the cogwheel rigidity. So rigidity, cogwheel type. Then there is tremor. Tremor is pill rolling type and is static tremor. Static tremor is that it is present at all time. Compare that to cerebellar tremor, which is intention tremor. When somebody wants to do something, the tremor appears, and if you don't want to do it, it disappears. In case of Parkinson's, the tremor is present all the time, and it is mostly a pill rolling type tremor. Most of the time, the tremor appears in the distal parts of the body. Then the masked phase. And basic problem is there is going to be a problem with the motor system, and part of the masked phase and the other motor problems are the same. The substantia nigra is not modulating or not helping with the tone properly, so the patient is unable to show the emotions, and so masked phase. Then the gait becomes very shuffling and small steps. This is called festinating gait or shuffling gait, and that is another sign and that you can see for the patients of the Parkinson's. With this, there are other things. For example, hallucinations are very common. Patient feels that there is something while there is nothing. Then another very interesting problem that they're seeing is that the REM sleep, during the REM sleep, our brain actually disconnects the body, and the body is almost paralyzed and we're dreaming. But in case of Parkinson's patients, that disconnection does not occur. So the Parkinson's patients normally keep acting out their dream. So in that process, they might hurt themselves because their limbs are moving, and they might actually hurt the person who is lying with them or sleeping with them. So these are some of the problems. Urination becomes a problem. There is urgency, there is frequency, and there is incontinence that can develop. The GIT muscular movement and problem with that can actually cause delayed emptying of the stomach, which would result in, of course, a stale food inside the stomach, and nausea and vomiting would occur. So all those symptoms, clinical problems can appear. But from a steps point of view, the important things to remember are, number 1, rigidity, cogwheel type; number 2, tremors, pill rolling type; and number 3, the problems with the emotions; 4 is the shuffling gait or fascinating gait. Guys, thank you very much for watching this video. Make sure that you like and subscribe, and if possible, share it with your friends as well.